Hello everyone, thank you for joining the latest Closomat and the OT service webinar. This one titled Bed-blocking and Occupational Therapy, Part of the Problem or the Solution. Now, as an occupational therapist myself, I'm very aware that when in creating this webinar and creating this title, it looks on the face of it like it could be challenging or done as a way of trying to create some kind of conflict. I've worked in acute services for 12 or 13 years, hospital-based services, and this is predominantly a reflection of experience, as well as on what the current challenges are and our experiences as the OT service of supporting both health and local authority organisations, as well as supervising a number of occupational therapists around the UK. So the idea is to provide some sort of reflection on what the current challenges are and maybe what we can be better at, potentially, in helping to solve them, or how we get ourselves in positions where we can have a bit more power, say, control over the future. I hope that's all right. So we're going to explore what bed blocking means and consider current statistics to reflect on our own, so that's our occupational therapy experiences. We're going to discuss current healthcare practices and processes to consider systematic challenges. We're going to reflect on occupational therapy practices and the impact on the discharge planning process. That's the one that's going to take up the bulk of the next half hour or so. And when I talk about the discharge planning process, this is not just about hospital-based occupational therapists. It's about how the discharge planning process impacts on the wider statutory services, in particular, occupational therapy group. So from health to social care. And we're going to explore what opportunities exist for occupational therapists to be key problem solvers, because there's absolutely no doubt that regardless of the title, we have a key role to play. We'll start by looking at what bed blocking is, as I've used that term in the title. I'm sure it's an expression that everyone will be familiar with, but it's something now we see predominantly within the media rather than within health and social care. And the reason we don't see it particularly within health and social care now is because bed blocking itself created the connotation that the patient was to blame. So the patient shouldn't be there, and therefore the patient blocked the bed. They were blocking the system from moving on. And we know that's very rarely the case. So the term now used internally within health and social care predominantly is delayed transfer of care. And the delayed transfer of care is very much based on what is now called a criteria to reside. And that was developed from the Hospital Discharge and Support Guidance of 2022. It was further developed within that document. It's something that people will have been familiar with for quite a while. So what mainstream media might call bed blocking, maybe to be sensationalist or to generate a reaction, internally is referred to a delayed transfer of care. I'm going to get into that in a little bit more depth. So for those of you who don't know, these are the questions that acute health services are asked about their patients, or the checklist they have to go through to determine whether somebody has that right to reside. And that in itself could seem a bit combative, because it's asking the question, does the person have the right to be here? But it goes through this set criteria. So does the patient require ITU or HDU? The answer is yes. They clearly have a right to reside. Do they require oxygen therapy or NIV? Do they require intravenous fluids? Is their news score greater than 3? Do they have a diminished level of consciousness where recovery is realistic? Do they have an acute functional impairment in excess of home or community care provision? I've put that in bold, clearly because it's the one that impacts us the most, and we'll come back to it. Is the patient in the last hours of life? Does the person require intravenous medication more than twice a day, including pain relief? And that's a really interesting one. We're not going to dwell on that an awful lot, but I'm sure that that would have a huge impact on community-based services such as district nursing. So essentially that one's saying if somebody requires intravenous medication twice a day or less, then that in itself isn't a right to reside. I don't know about yourselves, but certainly when I've been part of that discharge planning process, on many occasions, community nursing provision has said we're not able to commit to daily IV medication administration or something like that, likely due to resources. So I'm sure that one creates conflict within nursing or within medicine. Has the person undergone lower limb surgery within 48 hours? Again, there must be some more detailed criteria there because we're all familiar with same-day knee replacement discharges, so there must be some different criteria within that. Has the person undergone thoracic, abdominal, or pelvic surgery within 72 hours? If they have, then again, that is a reasonable criteria to reside. And is the person within 24 hours of an invasive procedure, which creates a risk to life? So they are the set criteria to reside. So if the answer is yes to any of those questions, then the person is able to be justified as remaining in hospital for that period of time. If the answer to any of those questions, if there is no to all of those questions, then the person is medically optimised. The term medically fit isn't used anymore. And in fact, during the Why Not Home, Why Not Today document and the discharge document I previously mentioned, it specifically says do not use the term medically fit or back to baseline. Now, during my acute health career, I saw that distinct change from medically fit being used all of the time to medically optimized being used. It was an overnight change. It felt like it was an overnight change. And my own reflection on that was that did psychologically on the people planning those discharges, certainly within medicine, create a very, very different objective. Now, I'm not saying I dispute or disagree with the term medically optimized or medical optimization. I understand it. Lots of people who leave hospital aren't medically fit and are never going to be medically fit in the sense of being free of ailment, for example. But it's the organizational or the cultural shift that is interesting to reflect on based on the term medical optimization. Because my reflection, my experience of that is that actually that leads to a lot more unwell people being discharged from hospital, or being more unwell when they leave hospital. What the term really means is that there are still things to do, there are still things to resolve for that person's acute medical ill health, but that they don't necessarily need to be in hospital for those things to be completed. Now, for the patient, the challenge there is, if I was staying in hospital to have those investigations done, would that be done more quickly, more efficiently? If I need a scan, can I not just go and have it while I'm here? Those sorts of challenges. If I'm going home and I'm still unwell, how do I manage during the day when I'm feeling more unwell, even if functionally I'm normally quite independent? And from a therapy perspective, it means that the challenges of somebody engaging in those functional or meaningful activities is far more complex. And we all know ourselves, if we're feeling unwell, if we have flu, or if we have DNV or some kind of other seasonal bug that actually the maintenance of what would otherwise be standard day-to-day activities becomes far more challenging. So you put that into an elderly care setting, say, for example, or a neurology setting, where there are far more complexities and comorbidities than actually somebody going home being medically optimized versus medically fit. Depending on how the organization internally and culturally is applying that, can make that far more challenging for the therapist supporting that person's discharge. That was my own reflection on that anyway. You might have completely different reflections and experiences, which is absolutely fine. But I do think that that culture of medical optimization versus medically fit has, from what I've seen, had an impact on discharge planning and then community expectations. So what does that mean for us as occupational therapists? I'm going to start with hospital-based therapists and then move into community therapists afterwards. So don't worry, nobody's being left out here, I hope. So I'm sure you'll all be aware that those documents led a number of years ago to the concept of discharge to assess. Now, discharge to assess was being rolled out pre-COVID. It wasn't something new then. I was working in an acute hospital trust in 10 years ago, more than 10 years ago, and we were already starting to think about the concepts of discharge to assess. We weren't necessarily using the term discharge to assess, but we were thinking of estimated discharge dates from the minute somebody arrived and that planning process. However, during COVID, this was expedited. So the term discharge to assess and the policy around it was expedited for obvious reasons, to try and increase the throughput of patients through hospital, and with the attempt to make things more efficient so that people were in hospital for the least amount of time that they needed to be because of other pressures. So discharge to assess initially is based on the identification of patients having different discharge needs. So as you can see there from the graphic, there's 4 different pathways, which I'm sure you're all familiar with. Pathway 0 is that suggestion that 50% of people entering the acute services require a simple discharge, require no input from health or social care. They come in, they leave, don't need to see an OT, don't need to see a physio, don't need to see a social worker, don't need to see anybody else as part of that planning process. Pathway 1 is that 45% of people need support to recover at home, or able to return home with support from health and or social care. So within the acute setting, this is what would create the bulk of an occupational therapist's caseload. So this is where there is a discharge plan to be processed. There might be some assessment required, there might be some follow-up required, there might be some support needed, reablement might need to be involved. And this is saying that 45% of people who hit the front door of hospital require that. Pathway 2 is 4% of people requiring rehabilitation in a bedded setting, so requiring inpatient rehabilitation. So again, they are patients who could be on our acute caseload, would absolutely be on the caseload of somebody working in an inpatient rehabilitation setting. But from an assessment perspective, to identify the need for inpatient rehabilitation, they would initially sit on our caseload as well. So 49% of people, therefore, who would be potentially needed for occupational therapy and our AHP colleagues during their acute stay. Pathway 3 is 1% of people where there's been a life-changing event where home is not an option at the point of discharge from the acute setting. Now, that 1% is an interesting area in my reflection, in my experience, because that 1% is something that, as part of this process, they suggest doesn't need that therapy in the acute setting. Now, I think that's based on resource, both people and time. If those were in place, I would suggest there was not a single person who would be needing to go into 24-hour care from hospital rather than back home, who wouldn't benefit from occupational therapy, whether that be as part of that planning process to be able to identify with the care home the person's routines, what the person likes, what they find meaningful, what their seating solutions are, what their sleep or bed solutions are, what their moving and handling needs are, for example, just to name a few. The truth of that is that pathway 1 and 2 end up being the core of our caseload, but pathway 3 often isn't. But I would argue also there has a significant need that is often unmet. So the issue there for me, in my reflection, isn't with discharge to assess. It's that if discharge to assess is misapplied, it can be used to avoid hospital-based therapeutic intervention, but instead diverting all of this to community services post-discharge. So if discharge to assess is used literally, so you discharge and then you assess everything completely, then that causes significant challenges elsewhere and creates risk. But that actually isn't what the policy says or the guidance says. And we're going to have a look at that in a bit more depth. So it's often about how discharge to assess is applied and whether there is misapplication by organisations who are seeing it as a way of creating rapid discharge rather than safe, structured, organised discharge, which leads to further assessment. So this is the flow chart that results from those pathways. And again, I'm sure many of you have seen this, but I just want to pick out a few points. So this is the first 50%. So this is the 50% within pathway 0, which says they come into hospital, they leave hospital, they need nothing. But within that box, so within that 50%, it says brief assessment of function. For example, transfers and mobility. So nowhere, even within that 50%, is it saying that the person shouldn't be at least, I would suggest, triaged. I know it says assessment there, but brief assessment often ends up being triage. So those questions at a handover, is the person mobile? Are they managing to get themselves washed and dressed? Are they transferring independently? The answer is yes to all of those things. They might well then be the 50%. But that's not an assessment. So there is nowhere within the policy where it says occupational therapists shouldn't be in hospitals, for example, which can often be one of the organisational challenges when we're, as the OT service, going around healthcare trusts supporting them with either organisational change or supervision or anything else for that matter. It's that we often get asked that question, or therapists will tell us they feel that challenges of we feel like we're not valued in the hospital setting, and that there is a plan to push us away from that hospital setting. And we'll come on to that in a little bit more depth soon to share some views on that. But it talks about there within those 50% of a brief assessment of function. So who does that? Is that nursing staff? Is that trusted assessors? Is it occupational therapists? Is it anybody as part of that multidisciplinary team to determine whether someone's pathway 0 or not? We've then got the 45%. So this is pathway 1. So these are the bulk of our referrals, or the bulk of our caseload within the acute setting. So these are 45% of people who have been determined within that first section as having some functional need, whether that be mobility, transfers, self-care, domestic care, anything like that. And in between the two, you've got there an alert to the single point of access where basic information is provided and information on the level of care required in the last 24 hours. That's it. The next bit is at home. So you've got that immediate health and social care assessment in the home environment with carer needs agreed if required. So there, at that point, you would be putting all of the things in place that were required to meet that need. So that could be just simple signposting and advocacy if it wasn't a service that you were able to provide, but the certain person could source themselves. The provision of equipment, which it clearly states as an urgent response if it's needed. Reablement support as an urgent response. So if the person is identified as having some rehab goals or some intermediate care needs within the home environment, and that is an urgent response. So we're talking, this is within 24 hours. Ongoing health intervention is required, so that would be district nursing or GP review or podiatry or anything else, any other AHP or health intervention. And access to community beds if in crisis. So that's access to respite, for example. The interesting part of all of that is, where does the planning for that discharge start and end? So in theory, all of this should happen, according to this, at home. Within that first 50%, there is no element there for, well, an identification of need or an identification of equipment that's likely to be required in that section, and an identification of moving and handling needs. What does the person need to be hoisted? Do they need standing equipment? Do they need profiling bed? These are things that historically would have been identified within the hospital environment, organized, put in place, and then it ready for the person to be discharged home. Within this process, certainly if applied in the way of the literal application, so the person being at home before all this happens, creates real challenges. And also who is doing this. So is the 45%, so this pathway here, is that happening using outreach services that are acute based, so using hospital-based occupational therapists or discharge to assess teams to dip out of the hospital to do these things, which again, I understand makes sense because you're not then draining community resources who are already themselves have huge caseloads and are incredibly under-resourced. And how much of that is being put on those community-based teams. So I have different examples of those. So I have examples of when this was first rolled out, of it being persons going home, on the phone, they're going home in the next hour, you need to go and sort it. To the community teams, to this single point of access, which leads to phone calls then to us from some of the people we supervise saying, this person's come home, they're on a standard divan bed, they've been hoisted in hospital, we can't get a hoist out until for X number of days. We don't have a same-day delivery service. What do we do? That isn't what discharge to assess, if you read the policy and the guidance, was intended to be. The intention was for the assessment to start the minute somebody hits hospital. So where it says on that slide, on the left-hand side, the brief assessment of function, for example, transfers and mobility, this is the end bit. So that's the bit that happens as the person has become or is becoming medically optimized. But the bits before it can continue to happen. So I spent a number of years working in A&E and those front of house services. I could, just because the person was remaining in hospital doesn't mean I couldn't start that process. I couldn't find out about their home environment, how they were functioning beforehand, their likes, their dislikes, what they what their goals were for leaving hospital, what their current transfer requirements were, and then hand that on to somebody who was working on a particular ward that they were going to, who would then follow that through. So at that point in time, when the person was becoming medically optimized, we could give a much more detailed description of what the person was needing when they left. That is its intention. But we have seen it misused, where it is literally the person's medically optimized. There's a phone call to a single point of access saying they're coming, assess them there, solve it. So the challenges for the occupational therapists working in the acute service there is most, but not all, are currently now work a 7-day service as occupational therapists. But a 7-day service is a little misleading because the Saturday and Sunday are often then skeleton staff. So you're troubleshooting. A full 7-day service would be, it doesn't matter what day somebody's leaving hospital, whether it be Saturday, Sunday, or a Tuesday, there are the same level of resources available as are on a normal, typical working day. So there are challenges with that. In my experience, people who are working at the weekend then get 2 days off during the week. So you've got, how do you cover that? And it is never a real 7-day service from an occupational therapy perspective. Although we've seen excellent examples of that within A&E, of how patients can be immediately turned home and turned around very quickly, so they're not having to hit back of house. I accept that. But that 7-day service, there's no point in occupational therapy having that fantastic gold standard 7-day service if supporting agencies and service don't have it as well. So how do we access some of the bigger bits of equipment? For example, the services often have some kind of buffer stock within a hospital, but if somebody's needing profiling beds or rising armchairs or something that you just wouldn't stock as standard within that, then how do you access that and support that discharge safely and at a high quality without access to those equipment services, the minor work services, the care agency point of contacts, the social care, all of those things that might be needed as part of that. Risk management, it can be challenging because often you feel like, or you can feel like, if it's misused, that you're not able to proactively manage risk or provide proactive risk assessment, because at that point of medical optimization, the person's gone to a discharge lounge and then off, and it depends how that's being applied. Resources, again, which I've alluded to, is how many therapists do you have on certain days? What are the covering rota structures, and what access do you have to other things? And most importantly, that organizational or institutional application of discharge to assess. How is it being used, and for what reason? What's the purpose of it? And what does that mean then for community-based therapists? So I'm going to go back to that slide for a moment. And a lot of this comes down to, again, how is it being applied, but who is doing it? Let's assume that this isn't part of outreach, because that isn't my entire experience. Let's assume, as part of this, that there are still organizations who put all of this onto community-based services. And I've seen that happen. So if that's not you and your organization, then fantastic. But there are still health and social care organizations who, as part of discharge to assess, I see them put heavily on social care. So I've seen social care OTs being asked, along with their colleagues, their MDT colleagues, to provide this assessment, this immediate assessment for that 45% group. So for them to meet the person at home on the day of discharge, an agreed time, to identify at that time what their needs are, what their care needs are, and then put those things in place. So in that position, you've got social care, occupational therapists providing an immediate need, so more like a rapid response service to support discharge to assess, which can be for some people with quite complex needs, made complex more predominantly by pace rather than anything to do with skill or knowledge, because this sits quite nicely within social care OT's skill base. They'd then be expected to do all of those second boxes, so put the things in place that were needed, including providing manual handling risk assessments, doing demonstrations and training with care teams, care providers if required, all of the things that would be needed to support that person to be safe at home. And then everything else that they do. So that third arrow there, which leads to my question of, well, what else happens below that? So what happens to those DFG caseloads and waiting lists, which, again, in our experience with the OT service, are huge at the minute, across the board, through adult and children's services. And we know because we're providing lots of local authorities with support for them. And if you have teams that are dedicated to support discharge to assess, and teams that are dedicated to reablement, and teams that are dedicated to DFG and housing, which is, in fairness, is often the case, I understand. It's, do all of those teams have the right skill mix? Or do they have the right resources? Do they have the right knowledge and training, depending on where they are, where they're sitting? And if you don't have those, but even if you do have those, it's you are diluting the skill, and you're diluting the personnel to pick up different needs. And the impact that then has on that bottom arrow is that the team who are just there to manage, say, adaptations of housing can't meet that demand. So you end up with waiting lists that could be 2 years or more. And those people then at some point become an acute issue. They become acute patients because potentially their social care needs are unable to be met. So it creates this whole vicious circle. If you don't have dedicated teams and you have a generic pool of occupational therapists who do all this, the problem's still the same. Is, do you have, but with the added challenge of skill mix. So how do you identify the right person going to the right patient? So the challenges that I see for social care occupational therapists within that process is who does what? What are the service responsibilities? Who's responsible for seeing somebody within an hour of discharge, providing moving and handling assessment, ensuring that equipment's in place, organising minor works, as well as having a caseload of DFG, major adaptations? Who does what? Who understands roles and responsibilities? Or is it just a case of you meet immediate need and then move on to something that's less immediate? I see skill mix as a big challenge. So often I see reablement teams having to pick up a lot of the slack. So reablement teams turning into immediate or rapid response teams as well. Well, for one, that diminishes reablement that people and rehab that people are able to have in their own home, which is the remit of the team. But also then, so say within something like patients who are CHC funded, reablement being asked to go in and provide some of those assessments for cases that can then get quite complex. So do you have the necessary adaptation skills and experience, for example? Moving and handling is a huge one as part of discharge to assess, as you can gather, because I've mentioned it quite a bit. Is everybody familiar with single-handed care or proportionate handling? Are you from a hospital-based assessment right through to the community? Are you organizationally doing the same things? Are you recommending the same things? Are you using the same equipment? Are you confident with moving and handling techniques that reduce care packages to make them easier to find or resource? Are you still, as a service, quite entrenched in somebody using a full body hoist, whether it be gantry or mobile, has to be 2 people or tends to be 2 people? What training are you provided around that to meet that that community need? And the same thing with DFG. If these teams are mixed, how do you allocate cases to people who may have less experience with DFG or more experience with something else? The 7-day service challenge is the same. Again, in my experience, it might not be the case everywhere, but 7-day services seem to be less prevalent within the community. So that has an impact on the acute service in terms of how they access those community services. But it also has an impact on discharge to assess if it's set up not as outreach and it's set up as how do we manage that on Saturdays and Sundays. And if you do have a 7-day occupational therapy service, there are still going to be challenges around, like in the acute service, how do I access all those other things that are only available to me on Monday to Friday? Resources generally, how do you staff all that? We're all very aware that there's a big shortage, there are vacancies in most organizations. How do you manage all of those 3 or 4 needs, those steps, whilst already being under-resourced? And again, the big one, how is your organization applying discharge to assess? That's the crux of it. That's the one that will have the biggest impact on health and social care occupational therapy services. If it's being applied well and as it's meant to be applied, then a lot of those challenges immediately go away. So how are we part of the problem? How could we be part of the problem? So this is the bit that could be quite challenging, but I mean it as reflection on my own experiences. Generic working, we often don't like it. We often like, rightly, to be able to express our occupational therapy values and what we do, and that idea of being jack of all trades or being managed or led by non-occupational therapists is something that, in my experience, we often don't like. We need to reflect on that and think about what the core AHP skills are, whilst being able to apply our occupational therapy values and philosophies around that. So how we document, how we goal set, actually how are we client-centered and holistic, and where is the best place for us to be holistic? I would argue it isn't necessarily in the hospital, but does that mean that we can't be occupational therapists in the hospital? Of course it doesn't. It just means that we need to step off that treadmill for a bit sometimes and actually think, even if the outcome's going to be the same, how do I record this in an occupational therapy way? How do I ensure that everybody knows what I am doing? What language do I use? How is what I've just done or asked client-centered? Am I asking, how do you do something? Or am I asking, why do you do it? Because the why is what gives it the meaning and makes it more occupational therapy. Our organizational role versus occupational therapy, that is a real problem. Sometimes, from what I've seen, we need to accept often that our job description fulfills an organizational role, and sometimes we can allow that to conflict with our occupational therapy role. There's no need for that, for exactly what I've just said. If our organizational role is to discharge plan, then there's nothing wrong with that. We just accept that our organizational role and what our organization wants from us is to plan discharge. Do they care that we're occupational therapists and we have different values? I don't know. But sometimes I think we need to remove that chip from our shoulder and think, actually, we can take some control over that. Once we accept that our role there is discharge planning or supporting discharge if we're in the community, then that doesn't mean that we can't do that in an occupation-focused way. If we can't resolve all of people's problems or issues, that's okay, as long as we're communicating what we can't do as well as what we can, and advocating or signposting the person to where they might be able to go and solve them themselves. But if we don't identify them as part of that process, then are we applying occupational therapy, and are we being client-centered? The answer probably is no. Change management doesn't just figure for occupational therapists, it's everyone, I guess. People tend to not like change, but in my experience, sometimes we need to embrace it more and consider how we can use change to further the profession within the organizations. How do we use our skills and our knowledge to say, this is who we are, this is what we do, this is how we can be more efficient, how we can help the organization be more efficient. The next question is for your reflection. Is the hospital the best place for us to be in order to be holistic and client-centered? My answer to that is you can be client-centered and holistic within the hospital. Absolutely. It's what questions you ask, how you record, and how good you are then signposting. You can absolutely be occupational therapists in a hospital environment. Whether we can apply holism in the term that holism actually means, I think, is a different discussion. I think you need to be in the person's own home and within their community to be actively holistic, but it doesn't necessarily mean that we can't start that holistic process. But again, that's for your own reflection. Caseload management. So my point on this is, and again, I'm not saying this about everybody who's on this webinar at all, but we as part of our supervision process that we provide for a number of therapists around the UK, we quite regularly come up against therapists who work full-time and who say how busy they are and have very small caseloads. And I'm sure that's the minority. I'm absolutely certain of it. But we need to sometimes, I think, have a look at when we close cases, when we're confident to say, actually, we've done everything we need to there, this is finished, it can be closed. Close, move on, somebody else can be picked up. At the same time, whilst I understand that we might be fatigued, we might be professionally fatigued, organizationally fatigued, but there is a point where caseloads that we have and how we manage, I think, put us in a position where we could be questioned as to how does that help efficiency. And I've only put that in, and I'm only saying it because I've had real experiences of that, of therapists who have, on the face of it, very small caseloads, and they're not particularly complex, but feel like they're run off their feet. And I think at that point, it's about looking at processes and how do we, as occupational therapists, accept that we've done what we can and stop, close, and move on. And also reflect on how busy we actually are. Now, I accept, like I say, I don't mean that to challenge. For the most part, we are incredibly busy and doing a fantastic job, but it doesn't do any harm every so often just to take a step back and reflect on that caseload and think, actually, is what I'm doing right? Am I being efficient enough? And knowledge and skills, that's how proactive are we at engaging in additional CPD? If you're here, you're engaging in it, fantastic. But yeah, I know, we deliver a lot of proportionate handling care training with A1 Risk Solutions. And those organizations that we're doing that for are engaging organizationally and strategically in something like single-handed care, for example. So what is your organization doing within those sorts of things to not only put plans in place, but to provide you with the skills and knowledge to implement them properly? And if you're not getting that, How do you shout up about it, source it, and take some control over what's required? And how are we part of the solution? So we offer problem-solving and solution-focused intervention. So we are, I think, and I'm obviously biased as an occupational therapist, I think we are some of the best practical problem solvers that statutory services have to offer. We're very practical, hands-on. We can find solutions to problems. That is what we do. And that helps our clients, our patients, and also helps our organizations to be efficient. How do we shout about that? Activity analysis is one of our unique skills. You could argue it's our USP. So being able to apply a robust activity analysis to transfer knowledge, skills, and need across all aspects of daily life is an incredibly efficient and cost-effective skill to have. But we need to shout about it more. We need to be better at documenting our activity analysis. On the Closomat website, we've written the activity analysis of toileting. It was written by students originally, and we've just, in the last year or so, provided it with an update. It's definitely worth having a look at. That's the sort of depth and detail that we should be communicating and documenting our activity analysis at. And we're uniquely placed to apply the CARE Act principles, which are empowerment, prevention, be proportionate, to protect, to be collaborative, and to be accountable. All of those things are core to occupational therapy. We empower our patients, our clients, to make informed, capacitated decisions and unwise decisions if they wish. But that is what we do. We provide people with information through robust clinical reasoning and evidence base. If we don't, then we need to reflect and challenge ourselves to do that better, particularly with the clinical reasoning and the evidence-based practice. We're preventative. We look at long-term solutions, which is cost-effective. We're proportionate, particularly within something like adaptations or DFG. We're making recommendations that, based on legislation, have to be proportionate. We care, we protect our clients. We're collaborative. We predominantly work in multidisciplinary teams. We are excellent communicators within that. And the accountability, I think, comes with clinical reasoning, robust evidence-based practice, and taking responsibility, which I think is something that, although we do it, every healthcare profession at the minute could probably be a little bit better at. We are incredibly cost effective because of all of those things, including future-proofing and then the impact on long-term health and well-being. The challenge is how we shout about all of those things, how we knock doors down to say, here I am, here we are, this is what we do, this is what we can bring to you. Be proactive, be innovators, be business people within, entrepreneurs within health and social care. And I know that's difficult because we're tired often and there are other things for us to be focusing on. But if we don't take time to do that, then it makes it more difficult for us to be able to complain about things that we haven't taken control over. So in summary, we've looked at bed blocking as delayed transfer of care and its complex multifactorial concept. Occupational therapy values and application can be challenged by organizational roles and obligations. We should be critically reflective of practice to ensure services are delivered when and where best to maximize our client or patient's outcomes. And occupational therapists are perfectly placed to support the resolution of health and social care crisis. And like I say at the bottom there, knock down doors. I've got myself into meetings that I was never invited to just because I found out that they were happening. I opened the door, sat down and said, I'm here because I think I can bring you this. And that's led to plans, to other things happening that at least I felt like as a service we've been able to then take control of. I would recommend you all did the same. Thank you.